the studies have now progressed to the point where there's large enough patients treated in these different diseases in different centers to start to ascertain some patterns of response and patterns of resistance across the different malignancies. And there are two interesting patterns that have emerged if you look at sort of CLL and ALL as opposite ends of the spectrum, where in B, acute lymphoblastic leukemia, there are very, very high response rates, really amazing 90+% response rates in patients who are refractory to all available therapies. But a sizable portion of them, maybe a quarter to a half of those patients, will relapse, and in most cases those relapse will be selection for CD19 negative disease, so where the leukemia has managed to downregulate the target of the CAR T cell or eliminate the target of the CAR T cell. The opposite is the case in CLL, where it does not seem that patients who initially respond with CLL tend not to relapse, but the response rates are lower. And in CLL, there's therefore a different problem where the T cells that you get from CLL patients may not be as active intrinsically as the T cells you get from ALL patients, but the disease does not have the propensity to escape the T cells the way ALL does. So you have two different mechanisms of resistance and two different patterns of response, and they lend themselves to different strategies to improve the efficacy and prevent resistance in each case. Right in the middle is non-Hodgkin's lymphoma, where you have a little bit of where you have slightly better response rates than CLL, but not quite as high as ALL, but still relatively little downregulation of the target as a resistance mechanism compared to what we see in ALL. Multiple myeloma is a new area, and I think we're eager to see in the multiple myeloma community how this disease responds to CAR T cells and whether it resembles CLL, ALL, or non-Hodgkin's lymphoma and the type of responses and resistance patterns we see. There at meetings in the latter half of 2016 and in a publication from the NCI, we have reports of initial results from phase 1 studies targeting BCMA, which is a plasma cell-specific antigen. And we have phase 1 results from, as I said, 3 institutions showing that this is a viable target, that there are responses in roughly half of patients treated. If you put together all the studies, it's still relatively small experience, including some durable responses exceeding 6 months. So this is very promising, and it's that durability that really is the promise of this therapy, the ability of this therapy to induce a long-lived immunity against the cancer in patients. That's what everybody is hoping for when they receive this therapy, and it has been it has played out that way to varying degrees in the different studies and in the different diseases. And I think that's the promise of this therapy, and the trick is going to be in the coming years to figure out how it can be improved to both improve the initial response rate, but also attain some of those really durable responses that we know this therapy is capable of, but is not quite a reality for all patients yet.